Ничего,
Катерина Осиповна.
Ну,
Но потом мы с тобой созвонимся. 5 минут еще у нас.
Да, 5 минут есть.
Скажите, ситуация с ковид. У нас идет просто бешеный рост. У вас тоже?
У нас тоже очень быстрый рост идет, больше 550 пацентов в день.
Уже... Это же, понимаем, мы выявленные.
Да, то есть это официальная статистика. Ей как
у нас тоже около 500 выявленных, и очень высокая смертность.
Смертность, и доктора говорят, что пациенты тяжелые, тяжелее, чем были, предположим, в первую волну однозначно. Перестают работать препараты для биологической терапии. Ну, не такой эффект, как был раньше. В общем, такие очень серьезные проблемы.
Еще ужас. Катерина Осиповна, берегите себя. И Марина Викторовна и Анастасия. Все.
Мне уже не страшно, я уже все переболела.
Так, а чего? И мы все, Марина Викторовна, мы все.
И
переболели, и привились. Не факт.
По полной программе, да.
Вы же знаете.
У меня еще есть, я вот только выздоровела.
Ну тоже не расслабляйтесь. У меня моя девочка заведует отделением самым тяжелым в нашей областной больнице ковидном. Привитые, переболевшие, недавно переболевшие, не имеет значения.
Нет, все правильно. Эта дельта, она такая, как бы, очень контагиозная, безусловно. Но все-таки те, кто привитые, болеют легче. Это да.
Вот правда, у нас профессор, вот помнишь Екатерину Осиповну, Катерницкую Людмилу Ивановну?
Да.
Наша была такая. Она же давно уже умерла, а ее муж, ну там из-за тромбоэмболии, мой муж известный у нас хирург, привитой, переболевший, умер.
Да ты что?
Повторно ковид.
Да ты что? Ну вот, я говорю, паршивая такая инфекция.
Поэтому, Марина Викторовна, берегите себя, не расслабляйтесь.
Ну, вот мы
Катерина Осиповна, а ты переболела или неизвестно?
Ты кого спрашиваешь, Настя?
Катерину Осиповну.
Я, видимо, переболела все-таки, но в такой очень как бы легкой форме. Вот. Но у нас Игорь Фомин заболел.
Сейчас?
Да.
Боже мой, да что ж такое? Я с ним только вела какое-то мероприятие. Боже мой. Екатерина Осиповна, я-то тоже легко, постфактум только узнала, думали, что ОРВИ. И я, и муж думали ОРВИ, проверяли все. А потом антитела и М, и G у меня оказались высокими. Ну, ладно, ничего.
Сейчас контроль такой безобразный. Вот я, если раньше сидела на приемах с больными практически каждый день, все-таки как-то было более безопасно. Сейчас ходят все, и терапевты направляют, и с обострением астмы на фоне ОРВИ. Какое ОРВИ? Ни мазков, ничего. Караул.
У нас мероприятия в стране очень плохо проводятся, совершенно не проводятся.
Да, так это ладно у нас на юге.
Бесконечное.
Екатерина, у нас на юге все понятно. С лета у нас как будто нет ковида. Почему? Курортный сезон. Вся страна у нас на юге была.
Да.
А вот сейчас, конечно, ну, а у вас-то нет курортного, у вас все должно соблюдаться.
У нас абсолютно, у нас праздновался юбилей города.
Да, ужаснулась, увидев это.
13 суббот было с артистами, с табуном
Здравствуйте.
народу.
У нас через минуту эфир, я вам скажу несколько секунд.
Да, извините, пожалуйста, мы наконец увидели друг друга.
Так, 9:59, да, я вижу. Вы нам скажете, да?
Да, за несколько секунд я вам скажу заранее.
Хорошо.
Я потом скажу, когда будем в эфире.
Хорошо. Так, 10 уже.
10 секунд. Мы в эфире.
Доброе утро, глубоко уважаемые коллеги. Мы благодарим всех, кто подключился к нашему симпозиуму, и мы продолжаем обсуждать новую коронавирусную инфекцию. Сегодня с вами поделятся своей информацией, своими впечатлениями люди, которые практически работают с новой коронавирусной инфекцией. И мы сегодня будем говорить действительно в большей степени о таких очень практических вопросах, которые касаются каждого врача, который работает с пациентами с коронавирусной инфекцией и который, может быть, напрямую не работает с пациентами с коронавирусной инфекцией, но он в любом случае сталкивается с последствиями перенесенной новой коронавирусной инфекции. И позвольте, уважаемые коллеги, в качестве первого доклада представить вам совершенно новую информацию, которую мы получили благодаря Международному регистру актив. И это сообщение сделаю я, но я его делаю, уважаемые коллеги, от имени всей исследовательской группы. Международный регистр актив осуществляется 7 странами. Организационный комитет возглавляет член-корреспондент Российской академии наук Арутюнов Григорий Павлович. На данный момент в регистре работает 26 центров и уже включено в регистр более 9000 пациентов. Дизайн регистра предполагает 6 визитов. Первые 3 визита – это данные ретроспективные из медицинских документов, и амбулаторная ветвь есть, и госпитальная ветвь есть. И последующие 3 визита, 4, 5, 6 – это контрольные телефонные звонки со стандартной анкетой, которые оценивают состояние пациента после перенесенной коронавирусной инфекции. И мой доклад посвящен коморбидности пациентов, которые заболели или переболели уже коронавирусной инфекцией. И самое главное, что бросается в глаза, и это было очень наглядно видно с самого начала пандемии, что у пациентов, которые заболевают коронавирусной инфекцией, очень много сопутствующих заболеваний. И среди этих сопутствующих заболеваний, безусловно, лидировала артериальная гипертония. Мы с вами видим по данным регистра актив, среди госпитализированных пациентов, это красные графики, было больше 60% людей, которые имели артериальную гипертонию, что превышало распространенность артериальной гипертонии, серые графики, в популяции. Среди пациентов также очень много было больных с ишемической болезнью сердца. Почти каждый 4-й госпитализированный пациент имел ишемическую болезнь сердца, что уже практически в 4 раза превышало распространение ишемической болезни сердца в популяции. И мы видим, что другие страны показывают примерно те же самые цифры. Сахарный диабет, по нашим данным, встречался почти в 18%. Ишемическая болезнь почек была у 7,5% больных. И онкологические заболевания в нашем регистре встречались не так часто. Всего 2,1% пациентов. Но зато в регистре актив было очень много пациентов с хронической сердечной недостаточностью, больше, чем во всех остальных регистрах, больше 16%. И было достаточно много пациентов с сердечной недостаточностью 3-4 функционального класса, почти 6% таких больных. Треть больных по регистру актив имела ожирение, что совпадает с данными других стран. И, как это ни странно, было не очень много пациентов с хронической обструктивной болезнью легких, это всего 4,6%, и не очень много курящих пациентов, это немногим более 5%, что также не противоречит данным других регистров. Ну и показатели, которые всегда, конечно, всех волнуют больше всего, это летальность. По данным регистра актив, в общем, во всей популяции пациентов летальность была 6,2%, а госпитальная летальность составила 7,6%. Мы определили факторы риска летального исхода. И вот здесь как раз очень хорошо видно, что коморбидность играет очень большую роль в плане неблагоприятного течения коронавирусной инфекции. Мы видим, что сердечно-сосудистые заболевания лидируют в качестве факторов риска летального исхода. Инсульт в анамнезе, фибрилляция предсердий, ишемическая болезнь сердца, хроническая болезнь почек, артериальная гипертония, инфаркт в анамнезе, анемия, диабет, рак, ХСН 3-4 функционального класса и только на самом последнем месте хроническая обструктивная болезнь легких. И мы понимаем, что основными факторами риска являются сердечно-сосудистые заболевания и сахарный диабет. Но это факторы риска летального исхода в остром периоде новой коронавирусной инфекции. Очень большую негативную роль в плане тяжелого течения коронавирусной инфекции играл уровень полиморбидности. Красные графики – это группа умерших пациентов. И мы видим, что в группе умерших пациентов было больше половины пациентов, у которых 4 и больше сопутствующих заболевания. И мы определили самые часто встречающиеся кластеры сопутствующих заболеваний и то, как они влияли на госпитальную летальность пациентов с коронавирусной инфекцией. И вы видите, что это сочетание сердечно-сосудистых заболеваний и сахарного диабета. И обратите, пожалуйста, внимание, в каждой из этих комбинаций присутствует хроническая сердечная недостаточность. Если только у пациентов в диагнозе была...
If the patient had CHF and in other combination with other comorbidities, that was quite a severe patient. He had high mortality risk. And a big problem are the patients who had acute periods of coronavirus, but unfortunately, well, they went through that, but that was not the end of their problems. And this is a completely new data about follow-up of patients after COVID, 3 and 6 months follow-up data. It turned out that practically 40% of patients in 3 months still had one of the symptoms which was really disturbing. The symptoms which stay for a long time was weakness and shortness of breath. Dear colleagues, I would like to draw your attention that the third and the fourth in terms of prevalence are fluctuations of arterial pressure and pronounced heart rate. And also there is a term post-COVID tachycardia, and we also saw that in our study. The patient also contacted doctors for non-elective treatment, and at least once, most patients even more, there were repeated admissions, 2.4 and 4.4 cases depending on follow-up, and also they looked for emergency care. And well, also the reasons for searching care: uncontrolled hypertension, And the leader in 40% of these reasons was uncontrolled arterial hypertension, decompensation of diabetes, ischemic heart disease, and number 4 are the GIT pathologies. And also decompensation of asthma, so was less frequent as for atrial fibrillation. And also there is a number of long COVID symptoms inquiries, and what was really concerning was de novo diseases. So these are completely new diseases the patient did not have before being infected. And those new diseases were found in 5.6% of patients in 3 months and in 6.4% after 6 months. After those de novo diseases were diagnosed, once again we see cardiovascular diseases, arterial hypertension, CAT, and the frequency prevalence was growing from months 3 to 6. There were new episodes of atrial fibrillation. Number 4 are different arthritis, and there were also changes in the brain and infarction or stroke and new heart failure. And also we try to find what are the patients which have it. These are patients at the age of 40, 59, they had obesity. And they had also C-reactive protein saturation and lymphocyte and fibrinogen levels. So they had certain deviations here. And also there were lots of cerebrovascular events. And so the analysis of post-COVID in patients with and without comorbidities. So the red ones are those who had them. You see that cardiovascular disease patients, which are the columns in red, they had more complaints as weakness, shortness of breath, fluctuations of pressure, accelerated heart rate, coughing, chest pain, and also that was true for 3 and 6 months. And in CVD patient group in post-COVID, there were uncontrolled changes of arterial pressure, chest pain, shortness of breath, and these patients looked for medical help more frequently, and they had uncontrolled hypertension, all decompensation, had paroxysm and atrial fibrillation, and the worsening of heart failure symptoms, and the same is true after 6 months. And also one of the factors was sputum to assess the post-COVID syndrome. Well, if we take the 10-point score, so the patients were losing more scores in terms of how they felt during coronavirus and after coronavirus. If we compare them against non-CVD patients, and by month 6 they were not restoring themselves, and we see very low scores for the condition of those patients as they often consulted doctor. They had the new prescriptions, ACE, beta blockers and stators were prescribed, and oral anticoagulants. The most important indicator is mortality in post-hospital period. 3 and 6 months after, we see that in general mortality in post-hospital period was 2.1%, but the vast majority of patients died quite quickly in the first 3 months. Mortality, 3 months mortality was almost 2%. And let us compare that against the acute period mortality. based on active register. If we look at mortality in different comorbidity groups, we see that the highest mortality rate was for patients with the chronic heart failure of grade 2 to 4. And then there was high mortality in cancer group and with other cardiovascular diseases, and it was a little bit lower for patients who had a chronic obstructive lung disease or asthma. Well, dear colleagues, the causes of death, we could not just learn the exact cause of death using phone calls, and we also have unidentified unknown causes of death, but even in those groups where it was clear what was the cause of death, the most frequent are the cardiovascular catastrophes, stroke, and heart failure, and other cerebrovascular catastrophes. And when we compared those who died and survived, these groups had quite a big difference. In post-hospital, those who died, they were older, and the severity was bigger, and also the number of breathing movements, saturation, heart rate, they have lower hemoglobin, lower lymphocyte level, higher level of DDMER, a lower speed of creatinine, of glomerular filtration, and lower kalium level. And also we identified top factors for mortality in the early period post-hospital stay, so over 80 years, and the low BMI, and the third is multiple comorbidities when he has 4+ comorbidities, and also acute kidney damage and deep vein thrombosis in acute phase, a stroke in medical record, a decrease of glomerular filtration 3B stage, atrial fibrillation, chronic kidney disease, arterial hypertension in combination with chronic heart failure. Other risk factors were arranged and prioritized in the following manner. And we see that the comorbidities were risk factors for post-hospital period, and the clusters of these hypertension plus CAT plus CHF, and also the acute period data was important, and the highly sensitive protein in acute periods, blood saturation, and just moderate decrease of glomerular filtration speed. The risk factors for mortality in the first 3 months for patients aged over 60. So polymorbidity is the main factor, 4 and more comorbidities, and we also see the same list of diseases which were risk factors for other patients as well, and they were risk factors for mortality in the hospital period. So, dear colleagues, cardiovascular diseases, cancer diseases, obesity, arterial hypertension, CHF, COPD, anemia, and polymorbidity are the negative factor for negative outcome in acute period of COVID-19. So weakness, shortness of breath, elevated AP, and heart beating, accelerated heart rate are the symptoms which stay for more than 6 months, and in 6.4% they had new diseases within 6 months, and among them were the CAT, arthritis, cerebrovascular events, arterial hypertension, the de novo disease would develop more frequently in patients aged 40 to 59. Those who had more acute and severe COVID, at least 1/3 of the patients during 3 months contacted for medical care, and the main reasons were uncontrolled elevation of AP, worsening of diabetes, CAT, and pathologies in GIT. Cardiovascular disease patients in post-COVID period suffered more. Mortality in 6 months after COVID was 2.1%, but most deaths were in the first 3 months. The highest mortality rate was in patients with chronic heart failure, cancer, and cardiovascular diseases. And among the cause of death, complications of cardiovascular disease amounted to at least 1/3. Dear colleagues, I would like to thank you for attention. We are waiting for your questions, and in the end of our symposium, we'll try to answer your questions. Now, that's a great pleasure for me to give floor to Doctor of Medical Science and Professor Mrs. Chesnikova, Anna. Good afternoon, dear colleagues. My presentation is about outpatient follow-up of patients with the cardio CHF after COVID-19. Dear colleagues, I do not have conflict of interest in this presentation. Of course, we all witness that over the past years, so the heart failure prevalence was growing, but after the data presented by Ekaterina Perlovskaya, we understand that this growth will be even more pronounced. Our patients with chronic heart failure just are moving in the circle: hospital, home, outpatient clinic, and back to hospital. The shorter the time to the next hospital stay, the worse the forecast, the prognosis, the lower the survival of patients with chronic heart failure. And this is a relevant topic for practical healthcare: how to improve efficacy of patient management in outpatient clinic to decrease the risks of repeated admissions, decrease mortality for these patients. So how we do follow up for patients with the chronic heart failure? We do that in line with Order 173N from the Healthcare Ministry of the Russian Federation, which identifies the patients who should be followed up by general practitioners, cardiologists. But dear colleagues, there were no guidelines for CHF patients with the clear identification of tactics, of the number of diagnostic tests to be performed. Dear colleagues, our working group developed guidelines for outpatient follow-up for patients with chronic heart failure, for general practitioners, and especially for the pandemic. And also, this is the workload for the primary care institutions, and these are the recommendations to be soon approved. The main goals of follow-up is to slow progression of chronic heart failure, prevention of hospital admissions, improve prognosis and quality of life, and prevent infectious and other chronic non-infectious diseases. Well, the patients with chronic heart failure of stage 1 to H, functional class 1 to 3, followed by GP at least twice a year. For stage 2A, optimal follow-up should be at least 4 times a year if necessary, a consultation of cardiologists. The second B3 grade 3 and 4, they should be followed up by cardiologists at least 4 times a year in case of stable diseases. And we know that we have shortage of doctors, and many patients with this severity of heart failure, they continue to be followed up by the patient. Of course, these patients need consultation of cardiologists and other specialists, and the recommendations clearly identify the list of interventions required and the list of indicators to be followed during visits, doctor visits. And today we also have different schemes of patient visits during the pandemic. You see what we should do during each consultation, the frequency of diagnostic tests, echography, ECG depends on the severity, and the recommendation clearly identify the outpatient consultation for CHF patients when on top of medical record physical examination if it's offline. We also do other things. Also, there is a need for a lab test with interpretation and diagnosis and diagnostic of comorbidities at each consultation. We also need to assess compliance and assess the efficacy to achieve the clinical and lab diagnostic indicators to adjust treatment, increase patient motivation, arrange vaccination against the novel coronavirus infection, consultation of specialty doctors, and compliance with their recommendations, and of course, dear colleagues, even in the situation of the pandemic, and probably especially in these conditions, it is necessary to timely do additional diagnostic tests, treatment, rehabilitation, identify patients who needs to be referred to high-tech medical institutions. Unfortunately, now we do not have opportunities for other types of treatment. We can do further consultation and training of these patients. Dear colleagues, we have been working in COVID pandemic conditions for 2 years, and now, of course, the sanitary resort therapy is stopped, and the management of such patients based on the spread, fears of spread of infections, and also the temporary recommendations on outpatient medical care were developed for patients with chronic diseases in conditions of COVID pandemic. Well, these recommendations were developed in May 2020 under the auspices of the chief specialist of general practice, corresponding member of the Russian Academy of Sciences, Mrs. Dropkina, and in May this year, they were optimized based on changing approaches to treatment of patients with COVID-19 in line with those recommendations. And of course, these recommendations, they pay attention to patients with chronic heart failure, and elective consultation should be postponed, and all of the diagnostic tests should be postponed. That was done last year, especially in the second half of the year. But dear colleagues, once again, we see the growth of infection rates And this limitation of elective diagnostic tests, I think we should further enhance work here because, well, actually, there is also there are issues with this recommendation, and the diagnostic tests and lab tests should be assessed on personal status, and the priority is for remote consultations. That should be a telemedical monitoring or consultation over the phone. These are audio contacts by phone that could be video consultations. They should be done by general practitioners of the district, and in conditions of pandemic. And we see that the district general practitioners, they have a lot of workload, and also the remote control and control over timely control. Here, the nurses have more participation, and also during the pandemic, the planned elective diagnostics and checkups are stopped, preventative medical checkups, and the doctors of departments of medical prevention can also help with the outpatient checkup, I mean remote consultations, to optimize these consultations by nurses and doctors, and also by doctors of medical prevention. And there are checklists which identify the questions, and depending on the answer to these questions, it is recommended to continue treatment or to make adjustments online or remotely, or make decisions on presence consultations, offline consultations. The patient should know that even if there is a need for a doctor's consultation, he needs to call the call center. He should not come to the clinic personally. He should use the reception of the clinic where he receives his medical care, primary medical care, and depending on the problems, it is decided which type of consultation will be provided. And these are the checklists. They are developed for patients with heart failure, which helps to assess the condition of the patient during remote consultations in terms of medical check-up, and also after that the tactics will be decided upon. The frequency of such check-ups is individual based on severity of heart failure, but it should be the same frequency which is at least specified by the guidelines. I hope that in the nearest future we will have the new guidelines for outpatient checkups for a patient with heart failure, and the frequency will be identified based on severity of heart failure. As of remote consultation result, there is a control medical record to be filled in, and we need to assess the delivery and efficacy of remote consultations and the efficacy of check-up with assessment of patient conditions. For a remote consultation, it is important to get the message through to the patient to continue taking all of the medication. If it's necessary to adjust medication therapy, well, this adjustment can be done remotely, including electronic prescription for medication, which is very relevant today. I would like to draw your attention to the following, dear colleagues. This is very important to talk to the patient. What is the purpose of those remote contacts? We remember the first pandemic month. Of course, everybody was confused. The patients were confused, and as we were, and around patient management tactics when they would reject, take certain medications, thinking that it could provoke the new coronavirus infection. That was a mistake. And also that was damaging our patient management, patients with the CHF. So we need to convince them to continue treatment and make timely adjustment. It is important to train patients on the control of their symptoms, which can be done remotely, including everyday weighing, which will help the patients to adjust the diuretic dosages. And we need to train the patients to recognize decompensation symptoms, to timely inform the doctor or call an ambulance. And also, CHF patients have high risk of severe COVID progression, so we should address vaccinations for those who did not have COVID and those who already had it. We know that it is still relevant. Everything what I am saying, we already know that there are cases of repeated infections, and there are lots of them. In case of COVID, patients with CHF should be hospitalized, admitted to hospitals, irrespective of severity of symptoms, given high probability of developing very dangerous complications. For those who already had COVID-19, it is important to continue basic medication treatment of CHF with the beta blockers, antagonists of mineral receptors, and also other medication if it is necessary, and also renin, angiotensin, aldosterone system receptors. And it is important to get the consultation in the first 24-48 hours, remote contact. And why we need such early consultation to timely assess the condition, prevent readmission, optimize treatment, and make the decision about emergency physical consultation to assess his condition. Also to decide upon ECG or echo diagnostic tests and optimization of treatment. The patient should be invited for remote consultation or offline consultation by GP or cardiologist, depending on the situation. And as early as possible, the patient should start physical rehabilitation and breathing gymnastics. It's super relevant problem for CHF patients. They have heart rate impairment. At least half of the patients without COVID, they suffer from it. And also the main cause of death is sudden death, and atrial fibrillation is the reason. So the more severe CHF we know, the higher the risk of atrial fibrillation, as we recently saw in the data presented by Professor Prognoskaya. The patients in COVID-19 at a post-COVID period have an increasing risk of atrial fibrillation. There is high frequency of this disease. Atrial fibrillation for CHF. What does it mean? Higher hospitalization risk, including readmission, and low survival of such patients, which needs adjustment. And for a patient who had COVID-19, one of the most frequent complications is arrhythmia and persistent tachycardia and atrial fibrillation, supraventricular tachycardia, atrioventricular blockades. So the patients also may have the ventricle tachycardia. And also we need to identify the symptoms ASAP. You need to do Holter monitoring or ECG to find out about those arrhythmias. And there is also high frequency. And what we do, so let us look at existing recommendations. We optimize treatment of heart failure with the optimal dosages of all of the medications with focus on beta adrenal blockers, and if they cannot cope with tachycardia, persistent tachycardia, we know that we can add ivabradine to beta blockers. I believe that the best patient management algorithm for arrhythmias is presented by the Society of Heart Failure Patients of 2018. So here it mentions what are the medications which can be used for patients, and cannot be used for patients with the left ventricle ejection fraction. And also we may use different medication here, and the factors of use of medication or the risk of certain cardiac death, and also the implantation of cardiofibrillator may be used, cardioverter fibrillator. And of course, we need to prescribe anticoagulants to prevent stroke, control of rhythms or ventricle contraction, and we also identify the risk factors which can be controlled, electrolyte balance impairment, and so on. And of course, dear colleagues, in pandemic conditions, well, for patients who had coronavirus infections, it is very important to also have patronage at home for CHF patients. So it is very important to have patronage, so home care, so they have low mobility and they have severe CHF. They require dynamic control, optimization of treatment, and patronage can be done by either a doctor or a nurse, who plays an important role here. And in previous studies, it was demonstrated that the patient follow-up strategy with patronage nurses for home follow-up dramatically improves the prognosis for such patients, and over 12,000 patients were included into this survey, and the nurse home visits were proved very efficient to decrease the mortality risk for such patients. And also there is a clear trend to decrease by 36% hospitalization risks. The goals of patronage, home visits, dynamic follow-up, identify worsening of condition, self-care training, training on self-control, control of compliance, control of medication, motivation training of family members, and palliative care. There is a patronage template developed for this purpose. It can be used by both doctor and nurse. We need to train our patients on all of the key principles that should be complied. We should assess efficacy of outpatient follow-up, decrease of hospital admission rate, decrease of loss of capability and capabilities, disabilities rate, and also we need to have the desired lab indicators, and I will not just mention that for the lab test, and we know that starting from July 1st, there is a order from the healthcare minister on deepening check-up for patients who had COVID-19. For all of the patients who had, starting from the second month after they were cured, and the first stage, this is the 6-minute walk test, and the second stage are changes of indicators which identify the need for echography, so we may timely identify the new cases of CHF and provide additional control of heart failure for patients after COVID-19. And we hope that we are going to also deliver perfect medical care for such patients, and will follow up them in an outpatient mode. Thank you for your attention, dear colleagues. Anna, thank you so much for your presentation, and now I would like to give a floor to Professor Arutunov Alexander. Alexander, you have the floor. Dear colleagues, good afternoon. Anna, thank you for being the second speaker, and I will just start my presentation immediately, straight away. So, 1 second. I hope you may see my slides. Everything is fine. Yes, yes. I would like to draw your attention to one important problem. For just 12 months, well, at least 15 months, we've been discussing the use of target therapy in patients, and we did a small survey, a small study, and then we may just ask the question, what are the factors which impact the efficacy of target therapy? And the data is for M17 blockers, M1IL6 blockers, and they are quite contradictory. They do not have high level of evidence. In the best case, it's 2B. They are in Russian guidelines starting from version 9, and now there are different blockers which are used. We selected one of them, and would like to demonstrate what we managed to do. This is information about conflict of interest, about the topic of this lecture. And also we have certain questions. For whom and when we should use target therapy, olakizumab usage, because they changed from one guideline to the other. And also the medication duration, what are the factors influencing efficacy of treatment. Let us try to answer why we should just speak about olakizumab, viloxazumab, tezepelumab, lots of other blockers. We have L1 and Akindra. Why olakizumab? Because interleukin 6 is the receptor and has a floating receptor, and it can be interleukin 6 if we block the receptors of free floating receptors. Yes, IL-6 is eliminated, but it's synthesized again. If we block IL-6, we can get better results. Of course, we just block one of them. It's alpha interleukin 1, IL-17. There are lots of parts of the inflammatory cascade, but it gives good results to remove the progression of cytokine storm. That's why we selected interleukin 6, and it gives good results, should give good results. What are the medication schemes? What we used, it was in July, August 2021, there were the guidelines number 11, CT12 plus 2 criteria, temporary recommendations, temporary guidelines. These criteria were reassessed, and also we did that based on that version. So who were these patients for whom alukizumab was used? Only intravenous. We are only talking about intravenous. Subcutaneous is in the past, before May 2021. In commentators, CT1, in line with guidelines, a little bit more women. They had dexamethasone, mean dosage, over 20 milligram dosage per day, only 18% of cases, which is not severe patients. Favipiravir, almost all of them received, and we split them into 3 groups: efficacy, insufficient efficacy, and unsatisfactory outcome. What is the age split? Most are just, this is in this year, this is probably wave number 3. See that patients who are 60 plus, from 50 to 70, patients who are admitted, they are not severe, and the Delta strain was everywhere. The cytokine storm would appear very quickly, and the patient would move from CT1 to CT4. We should understand that only timely medication on day 7-9 made it possible to stop this storm and stop its progression. What were the comorbidities in these patients? We see traditionally most of them had hypertension, 4 of them, so 38% has sclerotic changes, so 38 from 100, and obesity. We don't speak about excessive BMI, and then immune deficiency only, and that may be lymphoma or something, only in 4%, and coronary artery disease. And what is the amount of comorbidities? It was discussed here at the symposium, and the number of comorbidities will be discussed in terms of their impact on the outcomes. At least 1 in comorbidity in 22%, 3 or 4 in 30% of patients who were in the study. So this is quite a homogeneous, typical group of severe, moderate, and timely hospital admission at early stage of disease. This is the cohort. We're not talking about CT 3, 4, and just severe patients who are admitted just immediately ICU, artificial ventilation, and also extra body oxygenation. And also we need to come up with a recommendation for whom we use target therapy, and what is the number of criteria to be taken into account, which was analyzed. These are the criteria to the right. This is their split. So mostly that was saturation 94, 97 from guidelines 11. Number 2, so fever. And number 3 is lymphopenia. Well, 13% did not have any of those criteria. These were reassessed patients, and we analyzed that. And we analyzed that group, and they are evenly split between the groups. Say that those patients with 0 criteria are in one of the groups. We cannot do that. They are evenly distributed between the 3 groups. Most had 1 criteria, 2 and 3 criteria, were in 33 and 15%. Let us range them by efficacy, and how we are just ranging the results. For whom the efficacy was high and or low, and with the negative outcome, death, artificial ventilation, desaturation in the first 3 days, or the heart cytokine storm, or the CT grade was growing, and insufficient efficacy. The second dosage was open or hormonal treatment. CRB, C-reactive CRP was decreased by over 50%, and the rest, the group with the positive effect, it was 55 people, so the vast majority. And what are the hypotheses of efficacy? Number one, let us think. The day when we start treatment, does it impact efficacy if we take monoclonal antibodies, COVID globally? Even in the past, we spoke about plasma. All of those medications and substances, the day of treatment, had impact and influence on efficacy. Yes, we do have limitations. We have 100 people. We didn't have that influence. You see that most patients had treatment between day 7 and 9. When we have the delta for ancestor, it was the day 7, 9, 11, so on delta it accelerated. And so in the diagram, the green dots are positive, and the black are medium, mean, and the black is negative effect. So we should have a difference in terms of age, so but it's the same number. So maybe if we had 1,000 patients, probably in more advanced age patients, the early start could have some impact, but we cannot speak about that with 100 people. Initial CT grade, no significant difference, no statistically significant difference. This is not enough people. Saturation, well, that must have an impact indeed. No difference in terms of saturation, no trend towards statistical significance. So the initial saturation is acceptable for alakizumab in line with the recommendation number 11. So it neither was proved, the dosage didn't have any effect, and also daily dexamethasone dosage. And you see the trend that patients with negative outcome, they had a trend towards increase of dexamethasone, but 12 is not a big difference, but 12 and 20, this is not big difference. So what had an impact? Let us draw such an image. So we have two groups, good effect, insufficient efficacy. We see the same age, more or less, though the age is older, but because of deviation, so it's not statistically significant. In BMI, the same number of comorbidities, the same CRP, and the same start of therapy. And what was statistically significant? Arterial fibrillation, diabetes, and fever were statistically significant, and also they were the proven factors which had influence on efficacy of treatment with olakizumab for these patients. Arterial fibrillation correlated with the bad outcome, and we are going to voice that in the Eurasian GP Association. Atrial fibrillation is factor number 2 in terms of mortality. This is an important factor, and this is an accurate factor. Why atrial fibrillation has such an effect? Diabetes and fever. Well, we have a good prognostic model. Of course, with 100 patients, the sensitivity correlates and specificity of 57%. Look at the rat. Each 0.1 degree decreases the efficacy of treatment. The more pronounced inflammation, the less the efficacy. Probably in the next recommendations, we will have to make adjustments for high fever to get to the second dosage. Diabetes, its presence decreased efficacy by 38% because of adipose tissue, probably and some other processes, it requires further study concentration of IL-6 in diabetes, and these patients will require higher dosage. And here you may see that in the chart. And body temperature, yes, here there is a trend in good effect group. They had a lower body temperature. The higher the temperature, the higher the inflammation, more interleukin-6 and more mechanism. Probably others are involved. What is the preliminary conclusion? Alakizumab was efficient in majority of patients. It was efficient for moderate patients, and also in dosage when he was used in line with the recommendations. And also the second question about the glucocorticosteroids, it was proven for the mild cases. You see that corticosteroids did not prove their efficacy for flu mortality, and they had impact of bacterial pneumonia, non-hospital pneumonia. Glucocorticosteroids had influence on patients without COVID, and also they had impact on mortality from COVID. You know that in European guidelines, glucocorticoid dexamethasone in particular had 1A level, and it was proven for acute respiratory distress syndrome, and that was in group under 60, also on ventilation, and the target enhances the effect. Whether immunosuppression will be excessive if we block both IL-1 and 6, give anakinra plus alakizumab, yes, such suppression will increase the risk of bacterial infection. For mono blockade of IL-6, yes, so we need to have control, and we also need to control the bacterial infection, but this is relevant. And and in 11%, we had the bacterial infection or procalcitonin exceeding 0.5, but it was in 26% negative, but was within the norm. What are bacterial complications? Classic bacterial pneumonia, total COVID with the bacterial infection, empyema of pleura in one case, NOST post-alakizumab. These are the examples of bacterial complications to have place, and ulcer, stressor ulcer, active hormonal therapy without the pump inhibitors, proton pump inhibitors. What are the conclusions? Alakizumab have good efficacy to decrease the risks in the mean sampling for intravenous injection, improves clinical status, stops cytokine storm, day 7 today with delta. These are the optimal days for alakizumab. So what are our findings? Atrial fibrillation decreases efficacy, diabetes decreases the efficacy, high body temperature also decreases the efficacy. Higher dosage will be required. Use more powerful blockers, or to use them straight away. Interleukin-1 probably. Small dose of hormones may not be enough, may not be sufficient for high body temperature. We cannot use 12 milligrams. We need to use more than 20 milligrams. Most patients had at the same time over 3 criteria for target therapy, and we need to control the bacterial infection, changes of sputum procalcitonin test, and the increase of CRP. And also we need to control the condition of the oral and nasal cavity, whether we have fungi there. Now the treatment is done in line with the legal acts, which are guidelines number 12, temporary guidelines, where we have changed medication schemes for mild and moderate, the CT1 or 2, 2 plus criteria SPO2 97 3N, and the temperature is 37.5, 30.9, and the leukocyte count should be like that. We use this dosage. Talking about moderate, severe, these are different indicators: CRP 45, leukocytopenia, and higher body temperature. These are the changes which were introduced. The dosage is different, the same, which aligns with the data that we received, and 64,128, these dosage were not enough. That's why we can expect that if we start immediately with a high dose of 256 milligrams, that will be more efficient for patients with the severe COVID. If it's impossible to use this dosage, it can be 128, not 64, 128 with higher dosages of dexamethasone, 20 plus milligrams. In this case, understanding all of the risks, so the risks are like this black swan in my slide, understanding all of the risks behind hormonal target therapy, knowing those risks, we know how to manage them. We change the dosage properly in the very beginning. We can protect the patient, and we will be in the situation when this black swan will disappear. I just call everybody who still works in the red zone, who listen to my lecture. When you select the dosage of olkizumab, it has certain advantages. It blocks the EU6, not the receptors, interleukin 6 itself. If you block the receptors, interleukin stays, and if you block the interleukin 6, so the receptor have nothing to bind with. Just watch out for the dosage, and guidelines allow us to arrange the dosage. Sometimes high doses are more efficient, especially for high fever patients and diabetic patients. And this is the data from our small sampling. Thank you for your attention. Thank you very much, Alexander. And we are waiting for your questions. I see we already have questions. I would like to give a floor to Marina Boldina, head of Pulmonological Center of the city of Nizhny Novgorod. Thank you, dear colleagues. That was a great pleasure for me to listen. I would like to thank the organizers for giving me the opportunity to speak. And also, I would like to speak about the topic which deserves a lot of attention. And it requires, of course, further study, which is rehabilitation. And also, I would like to just present my experience. And I would like to remind you that lungs are one of the target organs for COVID infection, and the lesion grade will also determine severity of patients with the coronavirus. And today we know that what we have in terms of morphology in COVID patients and lung lesions, diffuse alveolar lesions and microangiopathy with thrombosis. It was proven by multiple studies using autopsy materials. Talking about the outcomes of these lesions, one of the authors, they just offer to come up with histopathological patterns, diffuse alveolar lesion, organizational pneumonia, fibrosis, bacterial infection. And we see that in acute stage, the main changes, according to them, diffuse alveolar lesions and microthrombosis. In 30% of the cases, bacterial infection that Alexander mentioned. The acute stage also may have organizing pneumonia look at the outcomes, subacute stage, lower percentage have pneumonia. And there are few fibrotic patients. Most patients have positive outcome of lung lesions, and over 53% of patients 3 days after they are released did not have any CT manifestations. And if we look at all of the patients who have COVID, around 5% have severe to critical symptoms. And let us look at their outcomes. 20% of patients die from those severe patients. Around 30 to 50% they have full recovery. And around 30 to 50% they have fibrosis. The patients who survive and have fibrosis, they deserve special attention, and there are also studies ongoing for anti-fibrotic treatment for these patients, so trying to find what are the markers. The patients who recover after severe COVID, they stay with the symptoms for a very long time. They lose their working abilities for a long time, and they should have rehabilitation because they cannot work for a long time. And Ekaterina presented active register over 1,600 patients. We saw how after 6 months of treatment, lots of symptoms remained. We know it's not only about lungs. This is a polyorganic pathology, COVID, and lots of patients on top of weakness, shortness of breath, they have sleep disorder, muscular weakness, they cannot endure physical activity. And if you look at CT and functional lung tests, part of the patients from this group were tested. 353 patients, half of them have changes in CT after 3 months, 1/3 have decreased diffusion ability of lungs. So medical rehabilitation as the main method of recovering these patients should be used, so we should start that early at ICU after the patient became stable. Of course, there should be consistency in terms of stages. I will speak about the outpatient stage. If we look at our clinical guidelines, here we may see the methods that we may use at the outpatient stage for rehabilitation. This is breathing exercises, physical exercises, nebulizer therapy, manual treatment, and so on. So lung rehab proves its efficacy. This is one of the presentation at ERS Congress, Pulmonary Congress, which proved the efficacy of 12-week lung rehab, and 100 patients were analyzed. 25 to 15% of lesions, and half had 75. So 12 weeks of rehabilitation can increase endurance. And 6-minute walk test was assessed. The muscular strength of upper and lower limbs improve, and Hart's questionnaire for depression and anxiety proved the improvement of the psychological state with the help of lung rehabilitation. And I would like to present our patient. This is our colleague. She had a severe progression of COVID. Patient, 51 years old, female, with the comorbidities that we may see. So these are the risk factors. She has obesity, hypertension, and she was practically 1 month at hospital from October to November 2020. She was taking all of the treatment, and she had the high flow oxygen, course CT, with the maximum volume. So the X-ray doctor said it was 60%. This is her CT at release, 48%. The quality of CT is not so good. It was just difficult for her to hold her breath. After she was released, shortness of breath, MRC4 saturation 92 to 93. She had the saturation quite significant when there was some physical activity, weakness, and unintense cough. We tried to follow her up. After 1 month, she could be outside without any fear, and we tested her lung function. She was studied quite well. There was ECG performed and echography, heart and FUS scales were used. And what we found in this patient, so she had impairment of lung function, though in terms of external breathing, there were small obstructive changes, 76, and after broncholytics, we did not see any changes. And diffusion impairment, diffusion with one single breath in, and alveolar volume diffusion practically 60%. So these are important deviations. What she received after she was released, she received glucocorticosteroids, and she had changes in FEV1, and glucocorticosteroids were cancelled. She was taking rivaroxaban, hepatoprotectors, and azilsartan and betaloc. And double bronchotherapy was prescribed, tiotropi olodaterol with the inhalator for 3 months, fluimazole 600 milligrams for 3 months, and breathing exercises and medical physical exercise. We used that methodological guidelines by WHO, and several countries participated in its development. It's very convenient for the patients. Breathing exercises were recommended with the consistent and intermittent positive pressure during exhaling, and also the exercise was increasing its volume. Well, also the physical exercise was increasing, so she was increasing the time of walking without stopping. She had to get to 30 minutes, at least 30 minutes, 5 times a day. That was a must. Start walking at least 1 hour after food. When she achieved 30 minutes without stop, it is recommended to increase the speed. If you have have this goal, then starting from 10 minutes 2 times a day, then anaerobic exercises for 20-30 minutes, 30 minutes. Resistance and load exercises are recommended. Middle weight is recommended, so, and she did physical exercises. She needed to restore muscle strength, so she had the dumbbells, and also the patients needed to use weight and resistance exercise at the same time. The stop signals to stop exercise if shortness of breath, coughing is enhanced, when she feels uneasy, tension in the chest, headache, then she has to stop physical exercises. And the same guidelines can be used for the patients about the level of physical exercise that they perform, and they clearly say if you can say one whole statement of phrase, one whole sentence without shortness of breath, you can increase the intensity. If because of shortness of breath, you can just not talk, just can say one word at a time, then the intensity is too much. What is the right volume? If you can pronounce a whole sentence with the pause once or twice, and you have moderate or even severe shortness of breath, then you are doing right. So this is the level of physical exercise that they should have. Another important point we need to check the saturation of oxygen saturation. So because it may be 95 and more, and oxygen saturation should be tested for physical activity 40 steps or 1 minute up and down, up and down. You stand up and you sit back and then check the saturation. We will assess the severity of patients, and so that we properly select the physical exercises. So not only at rest. As for medication therapy, so what do we use? Mucolytics if there is cough, especially with the sputum. We can use ambroxol, acetylcysteine, carbocysteine, bronchodilatators, of course, for COPD and asthma, and if you have bronchoobstructive damages. And if the shortness of breath persists, we could try bronchodilatators to decrease the shortness of breath. We can use them through nebulizer, or also we can use the inhalators in aerosol or powders, also glucocorticosteroids for asthma, for COPD, based on indication, and hyperreactivity of bronchus, and dry coughing with the signs of hyperactivity. For example, the patient responds to some smells and to changes of the air temperature or humidity. We could also prescribe the glucocorticosteroids for this patient. Budesonide proved its efficacy in acute phase of coronavirus and in post-COVID as well for those who still have cough with the signs of hyperreactivity. This is the rehabilitation for the patient that we had, and you see CT, and just it's in April. We see the wonderful results that we have for her in April. In CT, we see the matte glass zones, CT 5%, volume of a lesion, damaged volume, and at rest, the saturation is okay, and she doesn't have the saturation. Positive questionnaire results. The lung function is getting back to norm, and 6 months, and CT is almost okay. Yes, but the diffusion ability is low. Well, the changes are positive, the diffusion is decreased, and for one alveolar volume and single inhaling, which gives us shortening of breath and gives us food for thought which medication should be prescribed for severe patients who have severe injuries, maybe anticoagulants. And microthrombosis are also present in severe cases. And we need more data that should be also compared against the control group. And how to provide rehabilitation. When in line with one of the studies which compared patients with lung rehabilitation, of course, this is a small sampling group, the patients who had lung rehabilitation during 6 weeks and those who did not. And we see a difference in improvement of forced expiration volume and also forced volume, and the diffusion ability also improved for patients with lung rehabilitation. It's in green, and also physical endurance is increasing compared to control group in patients who had lung rehabilitation. Well, concluding my small presentation, we understand that medical rehabilitation is the main method for efficient rehabilitation after COVID. That should be a comprehensive approach, taking into account cardiovascular and other complications. And rehabilitation should start at early stage after the patient is stabilized, and there should be consistency between the stages. Thank you. Thank you very much, Marina. And dear colleagues, we have questions. We have some minutes left. We'll try to answer those questions. The first question is to me: what therapy is preferable for a young patient after COVID when he has this post-COVID tachycardia? Well, dear colleagues, this patient needs echocardiogram and he needs ECG, because tachycardia may be related to more serious damage of heart. If you suspect that this is myocarditis, and then you should do MRI. Why we should do this test? If he has myocarditis, then he will have limitations of exercise for active inflammation. He will have a different physical rehabilitation after COVID. If there are no severe lung damages, then beta blockers are prescribed. If there is a trend towards low blood pressure, ibuprofen can be prescribed. Anna, I think now your question is the next. Well, yes, dear colleagues, about the checklist. Yes, this is huge help for our remote consultation on the website of the National Medical Research Center for Therapy and for Preventive Medicine. And the chief GP, Mrs. Travkina, she's director of this center. So on their website, the magazine, Preventive Magazine 2020 appendix, it is about patient management for COVID patients, not only for COPD and other non-chronic infectious disease, and updated checklist, which was recently demonstrated in Preventative Medicine in magazine in September. So this is the new updated version there. Marina, question for you. Would it make sense to do a repeated CT? Should I prescribe antifibrotics for patients with lung fibrosis in post-COVID? Well, as of or today, I just did not understand clearly when we do CT that we should not be done early. So the control CT should be done 6 months after antifibrotic treatment. So there are ongoing studies this year of the patients who start fibrotic lesions, and these fibrotic lesions have truncal bronchospasm, reticular changes. Well, in the future, they may develop other conditions, but it needs time. To say that antifibrotic treatment should be used, well, ongoing trials, yes. And only for the patients, we will have fibrosis of the lung tissues. Now they're trying to figure out the markers of fibrosis. What patients are more prone to them. Now we are still collecting data, and still will not prescribe this treatment for the patients for fibrosis. Well, it requires time still. We have patients who had COVID 1 year ago, and now in CT we see the same changes, and they are transformed to reticular changes and to fibrotic changes of bronchiectasis. Yes, this patients for these patients, antifibrotics will use. A lot of questions about alakizumab. So Alexander has left, right? Marina, could you say something about complications in alakizumab treatment? Do you have your personal experience? I think Alexander could just answer this question. I work more with post-COVID patients. Then we skip these questions. I will answer the question about the patient who doesn't have COPD for spilled respimat. We have spirometric changes. It's not only my opinion, but I will just send you to the website of our Society of Therapists. They have guidelines on rehabilitation. It was developed by Malyavin Babakin, by outstanding pulmonologists. If the patient has persistent shortness of breath, bronchodilators could be prescribed if it improves the condition, and the more advanced molecules should be used, spilled or double dilatators, which are very safe, extremely safe, probably not as bronchodilation, because in COVID infection, epithelium of airways is also damaged, and we know that they restore the epithelium. We know about cholinolytics also have anti-inflammatory action. Probably we're just also waiting for some effect in here, but what the patient had, and it's not only one patient like that, so they have decrease in shortness of breath, and well, these medications are highly safe. Respimat, easy to inhale, and you need not a lot of power, so that's why it was selected. Inhalation. And then anti-hypertension therapy for patients after thrombosis. Dear colleagues, if there is thrombosis, we understand that the patient is taking anticoagulants, and anti-hypertension therapy should be efficient. In this patient, we must properly maintain the target level of AP, arterial pressure. Well, basically, the recommended treatment from clinical guidelines can be used. All of the medications recommended to have a RAS inhibitor, at least one. And we have in the second half of the day our symposium, where we are going to speak about support therapy for patients with coronavirus. And that's a pity that Alexander left, and the last question we have to finish. So Marina, about physiotherapy as rehabilitation. You may open clinical guidelines. The different physiotherapeutic rehab. I used ultrasound, magnets, and we also tried hyperbaric oxygenation and radio frequency, and we have small studies about efficacy of different methods. So using this data, and all of this data, and based on that studies, they were included into clinical guidelines. For now, we're just trying that. Dear colleagues, our time is up. I would like to extend my gratitude to our speakers for their wonderful presentations, and these presentations are very practical and they're important in our work. I would like to say goodbye, wish you good night, good health, and we are waiting for you at next symposiums. Goodbye. Goodbye. Thank you for your attention.
Минута.
Анна Ивановна. Быстрее меня никто не открывает. Я, по-моему, вообще как чемпион.
Так, сейчас
Ладно.
Екатерина Ивановна задала тон. Сейчас будем
Да, по
тараторить.
открыванию симпозиума.
Ну, если что, я скажу, ну и так далее.
И так далее.
Да,
Ой, нет уж, Анна Ивановна, давайте как-то это самое
ладно.
мирными средствами.
Ну, я постараюсь.
Сейчас эфир.
Мы в эфире.
Добрый день, глубоко уважаемые.
Good afternoon, dear colleagues. We are happy to welcome everybody who has joined our symposium. And here we have pulmonologists and cardiologists. And today we are going to discuss the following topic. We have lots of things in common between pulmonology and cardiology. We share common problems, not only due to COVID, but due to other diseases as well. And I would like to give floor for presentation Professor Chesnikova Anna.
Добрый день, глубоко уважаемые.
Good afternoon, dear colleagues. And one of the relevant topics, and we have patients with cardiovascular diseases and chronic obstructive lung disease. In this presentation, I do not have any conflict of interest. So, dear colleagues, the most frequent comorbidity for COPD are the cardiovascular diseases. The prevalence of ischemic heart disease up to 60% and more. Hypertension is seen in over 80% of cases, cardiac insufficiency or failure in 35 to 25%. Arrhythmias are very frequent in 80 or more percent. The risk of atrial fibrillation in chronic obstructive lung diseases is increasing by more than 4 times. Even with moderate chronic obstructive lung disease, in presence of CVD comorbidities, in presence of heart failure, there is a significant increase of all of the cardiocerebral and vascular events, and the general mortality is growing. CHF in COPD. Well, heart failure is a predictor of death for this category of patients with COPD. In 40% of COPD patients have symptoms of dysfunction of left ventricle, and this initial symptoms of cardiac insufficiency or failure, they are not identified timely, and they may be also considered as exacerbation of COPD. It means that there won't be treatment of heart insufficiency for these patients. On the other hand, 30% of patients with CHF have chronic obstructive lung disease and COPD as comorbidity decompensate heart failure. The combination between COPD and CHF, according to 12-year studies, increase the mortality rate of patients compared to only cardiac failure or only obstructive lung disease. The risk of death is increased by more than 3.5 times if there are two diseases present. This is a clinical case. Patient 66 years old, male, has chronic obstructive lung disease for 20 years. At present, COPD third grade in gold, bronchophenotype, all signs of chronic lung heart decompensation, CAD in history for 15-16 years, arterial hypertension, now third stage, uncontrolled hypertension, so the risk is 4, and has a chronic heart failure with interim ejection fraction 48 to a functional class 3. And we understand that heart failure is of mixed genesis due to presence of chronic lung heart and pulmonary heart and also hypertension. And patient also has arrhythmia, tachycardia, extrasystoles of ventricles, and there is no consistent medication predictors of negative prognosis for COPD and chronic heart failure. And this is the arterial hypertension and chronic heart failure, third, fourth grade, and also third, fourth stage of COPD. But the biggest contribution to negative forecast is done by the lung hypertension, and it should be also treated in order to decrease the pressure in the small blood circulation circle. And we need to use prolonged blockers of calcium canals, as in guidelines they can be used for these patients with a low and interim and moderate ejection fraction of the left ventricle. And one of the indications is lung hypertension with also COPD. The patient has a heart failure of mixed genesis, and there is a question which arises: what are the peculiarities of use of the first-line medication to treat such patients? And here I would like to emphasize that there are studies which proved the role of RAS in pathogenesis, and also there are effects of activation by RAS. Also there are fibrotic events and other events, and the blockade of renin-angiotensin system is the new therapeutic strategy for patients with COPD, decrease of activity, and of course it will help and give us positive effects to treat the obstructive lung disease itself, and also inhibitors of ACE. So there are also positive effects, and also we can impact the obstruction with the help of angiotensin II, decrease the inflammation, vasoconstriction, and decrease the pressure in the lung vessels. and also improve alveolar gas exchange, and also will be able to control these indicators and also decrease beta-2 agonist-induced hypokalemia, which is important for patients with heart insufficiency. Of course, the choice of RAS blockers is important. We knew that inhibitors of APF are the first selection, but cough is difficult to be assessed, whether it's because of the inhibitors or this is progression of COPD. And also the frequency of ACE blockers induced cough is very low, and our patient, when we speak about ACE inhibitors, or we should use another medication, and also we could use ARNI, and the patients with symptomatic chronic heart failure, it can be valsartan, sacubitril, beta adenoblockers, and for a low ejection fraction, decrease ejection, and aldosterone antagonists to decrease the risk of cardiovascular death and hospitalization. What about beta blocker, adrenoblockers for these patients in our clinical case? If there was CAD, there was stroke, there are arrhythmias, heart failure. So how do we decide to use beta blockers? Until now, dear colleagues, the limitation of beta blockers for patients with COPD was because of bronchospasms. As for clinical guidelines, the clinical guidelines for patient management with chronic obstructive lung disease tells us that it is necessary to prescribe beta blockers to patients with cardiovascular diseases if they are indicated, especially for patients with heart failure, because selective beta blockers don't have adverse events and side effects, and selective beta blockers have no negative effect on functional indicators. So the first, second, forced expiration volume. Yes, if you use carvedilol compared to bisoprolol, carvedilol worsens bronchial patency based on the first, second FAV. Well, dear colleagues, based on recommendation, carvedilol is non-selective beta blocker with alpha blocking action. Then for CHF out of 4 will have the selective beta blocker bisoprolol, metoprolol, nebivolol, and we are going to choose from them. How important these drugs are for cardiovascular patients in combination with COPD. So we may look at meta-analysis and studies patients with COPD after infarction. When we prescribe beta blockers, they have improvement of prognosis and the risk of death is decreased by 40%. And also we know that we need to assess efficacy of sartan for infarction patients and post-infarction patients. The patient had infarction, and two upper curves, patients with chronic obstructive pulmonary disease, patients in after infarction and post-infarction, follow-up after up to 24 months. Dear colleagues, patients had lower mortality in case patients had beta adrenoblockers. Well-known meta-analysis, one of the biggest one, 15 observational studies, over 121,000 participants, patients with obstructive lung disease. COPD and ischemic heart disease. In case of beta blockers prescription, the risk of death decreased by 36%. Patients with COPD with heart failure, the risk was decreased by 26%. And in the same meta-analysis, it was demonstrated that beta blockers decrease the risk of COPD exacerbation. Beta adrenal blockers play an important role for treatment in CHF. Hyperactivation is the basis of pathogenetic characteristic not only of the heart failure but chronic obstructive pulmonary disease, and the mechanism are common. Selective beta blockers can be used and non-selective cannot be used. A low titration of dosage, especially in case of exacerbation of COPD, the use of M-cholinelytics with long-term effects may prevent potential bronchospasms. And of course, it is important to my mind to understand that the long-term use of beta-1 adrenal blockers increase sensitivity of beta-2 adrenal receptors, which enhances their bronchodilation action. As for diuretics, you need to be careful and prescribe that with a lot of care in line with indications when there are some signs of edemas and retention of liquid and contraction of and decrease of intravascular fluids after taking diuretics can decrease ejection fraction and may increase progression of disease and increase viscosity of blood, and may also increase viscosity of sputum. I would like to draw your attention to the following. We understand that we need to control kalium level, but in this case, hypokalemia may be triggered by systemic glucocorticoids and diuretics and agonists beta-2. So then we need to control the electrolytes and agonist mineral corticoid receptors. And we need to remember that diuretics may decrease breathing activity, increase hypoxemia, hypercapnia. Inhibitors of carbohydrates in chronic breathing failure decrease hypercapnia. Well, arrhythmia is very relevant topic for COPD patients. This is a persistent sinus tachycardia because of bronchodilatators, especially when there is abuse of the short-term beta-2 agonists by the patient, arrhythmia, extrasystole, atrial fibrillation. That is a separate topic. But dear colleagues, please just control the heart rate if the patient with COPD has heart failure. We know that patients with heart failure in increase of heart rate up to 70 has worsening of prognosis, and the risk of death and hospital admission for heart failure and cardiovascular risk is as well increased for mortality. At any stage of disease, if the heart rate is over 85, the survival is considerably worsened. And heart rate control is even more important when we have combination of heart failure and COPD. What are the drugs to be used? Beta adrenal blockers and inhibitors of IF canals, ivabradine, and and also we need to be very careful with these diseases. So with the verapamil and diltiazem, they are contraindicated. And of course, take into account arrhythmia, so we should focus on beta blockers. Another indication is beta blockers for these patients. The use of statins with ischemic heart disease. So the statins, will they help ours or not, or vice versa? They will damage treatment of COPD. Dear colleagues, I would like to draw your attention. With the statins, the functional indications, the VF in the first second, forced expiration volume, the statins improve the patency of bronchus, and the survival is higher for those who take statins compared to those who did not. In this clinical case, I would suggest beta-adrenal blockers. They are possible in combination with ivabradine, so I would suggest valsartan or sacubitril. We also have inhibitors of natrium glucose transporter type 2, which in line with current recommendation European guidelines we should prescribe. To improve prognosis, we have 4 classes of medication, and blockers of calcium canals also should be prescribed. And dear colleagues, prescribing all of these medication, of course diuretics if necessary, we need to take into account a Hubble treatment. Beta-2 agonists of short-term action, they may cause persistent failure and arrhythmias, but the long-term beta-2 agonists do not increase the risk of cardiovascular events. And so the short-term agonists should be limited because they may decompensate heart failure. But the problem is that patients take them when necessary, and they may abuse, which may lead to complications. The long-term agonists are safe. Anticholinergic drugs are the drugs of first choice, but that of prolonged action, such as tiotropium bromide, and some of them may increase the severity of heart failure. The long term, they do not cause any arrhythmias, and they are the selection for patients who have chronic obstructive pulmonary disease and patients with heart disease, heart failure. Thank you. Thank you, Anna. I would like to give floor to Professor Natalia Grigorieva.
Добрый день, глубоко уважаемые коллеги.
Good afternoon, dear colleagues. Talking about cardiorespiratory comorbidity, we speak a lot about patients with chronic obstructive pulmonary disease. We forgot that patients with asthma also have different comorbidities as well. And according to several studies, the most frequent comorbidity are also cardiovascular diseases. Of course, it is not so frequent compared to chronic obstructive pulmonary disease patients, and we try to answer the question how often such patients have combination of coronary artery disease or ischemic heart disease, have a combination with asthma. So we analyzed the clinic's population. Turned out that patients in 16% of cases have asthma as comorbidity, and these results were unexpected because this CHD just repeats the German study. What are the peculiarities of treating coronary heart disease with asthma? Almost 70,000 patients were involved in 11 studies, and there was meta-analysis which says that the risk of ischemic heart disease in asthmatic patients is 35% higher. The impact of asthma is higher in women compared to men. And we understand that asthma is a different disease. And in the recent qualification, well, we have as foundation the phenotypes of asthma. Allergic asthmatic patient is a different compared to non-allergic asthma or asthma with late onset. If allergy asthma has its onset in young patients, then the relation to CHD, well, it's kind of improbable. And talking about late onset asthma, according to meta-analysis, there is correlation with development of coronary heart disease. Asthmatic patients, especially patients with an badly controlled or non-controllable asthma, have a high risk of atrial fibrillation. How severe are the patients with chronic lung disease and CHD? This study covers not only patients with asthma, also chronic obstructive pulmonary disease patients are analyzed, and patients with severe phenotype overlap syndrome. So when the patient has both obstructive pulmonary disease and asthma. So you see, so the more severe the patient is, especially ACO phenotype, ACO phenotype, so the higher the risk of hospitalization with CHD and asthma, and higher are the rates of death, hazard ratio from coronary heart disease, and also the risk of arrhythmia is quite elevated. And also they may have infarction, of course, patients with asthma. If we take all patients with acute coronary syndrome, according to this study, well, among them there are few patients with asthma, only 3%, but nevertheless, taking 7,000 patients makes it possible to analyze those patients, whether they have any peculiarities of development of infarction in patients with the asthma. This is the mortality rate in hospital mortality and post-hospital mortality. And so there is no difference, but we see some peculiarities of myocardial infarction in patients with asthma. So firstly, it is diagnosed lately, and it's clear why, because patient who has asthma very often may relate it to exacerbation of asthma, not thinking that shortness of breath may be manifestation of acute coronary syndrome. And we know the asthmatic variant of infarction, which is present in patients with the chronic lung and bronchial diseases. And asthmatic patients have twice as much infarction without elevated ST. Reperfusion is also related to late admission to hospital. And probably the doctor won't be able to understand what's the problem, especially if there is no elevation of ST. And the next question, which is probably very relevant when we speak about patients with infarction and asthma, it's a prescription of beta-adeno blockers. And of course, it is done rarely or practically not for these patients. Though there are studies, and here we may see the mice studies, but they demonstrate that in presence of asthma, the CVD mortality risks are elevated. And we need to maximize our efforts to improve prognosis for patients with asthma. Well, the traditional medication to treat coronary heart disease for asthmatic patients are the calcium antagonists. Of course, we all know the positive effects of this medication. Correction of hemodynamics in the lungs, relaxation of bronchus muscles, and also of smooth muscles, and also decrease of inflammation, which is important. If we look at the recent recommendation for chronic coronary syndrome, and if we try to understand what kind of anti-anginal medication we should prescribe, there is no mention of these patients, and our guidelines neither specify that, but we have the COPD patients, and we need to try to understand what kind of drug is preferable in a specific situation, though the guidelines say that the selection of treatment will depend on comorbidities, and also, like in the previous version, we are guided by the algorithms in anti-anginal treatment, and those are the 4 steps. This is step-by-step approach based on personal characteristics, offers us to in 3 of 5 cases to select between a calcium antagonist and beta-adrenal blocker. And we have one situation, heart failure patient, especially patients with chronic heart failure with a low ejection fraction. And we understand that beta-adrenal blockers, this is the medication which impacts a prognosis of life of these patients. On top of that, and also it was mentioned by Anna in the first presentation, patients with chronic bronchus and lung pathology, they have sinus tachycardia, and the elevated heart rate is another factor which may cause rupture of plaque and cardiovascular accidents and catastrophes, and BABs can decrease those risks. Can we prescribe beta-adrenal blockers to a patient who has asthma? Let us try to understand how these medications work and what kind of drugs we have available. Of course, we need to speak about highly selective beta blockers, because then there is the effect on beta-2 blockers. So this is what we should take into account for asthmatic patients because of comorbidity. The long-term use of BABs decrease inflammation in bronchus and decrease the risk of death due to a beta-2 agonist, and they are often used for attacks of asthma. We understand perfectly well that non-selective beta-2 agonists may trigger electric instability of myocardium and will cause tachycardia, and one of the options how to fight these effects is prescription of beta-adrenal blockers to our patients. And also, it is demonstrated that the long-term use of BAB improves the bronchodilatational effect of beta-2 agonists that we use for asthmatic patients in the long term. And asthma, is it contraindication for beta-adrenal blockers? What evidence do we have about absence of negative impact on prognosis of life for such patients? Well, this is an old study which demonstrated that infarction patients, including patients with asthma, so they analyzed not only patients with COPD but also with asthma, the use of beta blockers decreases by 40% the risk of death. Unfortunately, we do not have the data on the pathologies in lungs and bronchus, and the mortality from pulmonary diseases did not increase. And we have databases which analyze both selective and non-selective beta blockers in patients with the different severity of asthma, and only highly selective beta blockers are safe, they concluded, and this study for ACO syndrome, for ECHO syndrome, demonstrate that highly selective beta adenoblocker can decrease patency, and the use of highly selective beta blockers, bisoprolol and metoprolol, is absolutely safe. What the instructions say? When you prescribe beta blockers to asthmatic patients, we need to follow the guideline, the instructions, and we need to do that in any clinical situation. You have the 4 most frequent beta adenoblockers. We have the regional drugs here. And let us look at contraindications where asthma is. Talking about bisoprolol, here it's very clear that severe asthma is a contraindication for beta adrenal blocker. We may conclude that for severe and moderate, in special clinical situations, the patient who has cardiovascular pathology, we may use this medication. As for metoprolol, with care, without specifying what kind of asthma, nepivalol, well, to my surprise, contraindications say asthma in patient record, though it's a highly selective beta blocker, and carvedilol, and asthma is contraindication because this is a non-selective beta blocker. As we do not have clear instructions in which situations and dosages we may use beta blockers for patients with asthma, we did such a study. Quite a complicated design. It was difficult to select patients because the inclusion criteria was not only asthma, mild or moderate and persistent, but the patients with control asthma. Only after it was under control, the patients were converted using the free conversion method to a group, and they would receive bisoprolol, BAB, and then by titration the dosage was increased. What were the results? Talking about mild persistent asthmatic patients, here a titration up to 10 milligrams of bisoprolol did not worsen bronchopatency, so we may conclude that it is safe for these patients. And the analysis of other indications, so heart rate, made it possible to speak about advantage of this type of medication for patients with CHD and mild asthma. Talking about moderate persistent asthma, when the dose increased from 5 to 10 milligrams of bisoprolol, there was a statistically significant decrease, though the patients did not mention that their condition worsened. So there was a decrease in FAF1, and heart rate was also controlled, and also we analyzed other indicators, but the decrease in FAF1 made it possible to conclude that we should not have higher dosage in these patients and use the therapeutic dosage. And this is our study. Probably this is one of the studies which will continue because the management of patients with cardiovascular diseases and asthma is quite interesting and relevant, and also the study looks quite optimistic. It is optimistic study, so for new beta blockers are studied, and also different formulas are studied to increase selectivity, and in the future we'll be able to use highly selective beta blockers for many groups of patients, and they will be safe. Thank you for your attention. Thank you very much, Natalia. I would like to give floor to pulmonology, head of Municipal Pulmonology Center from Nizhny Novgorod. Natalia Maria Boltina. So I would like to thank the organizers for the invitation. A lot was just said. Yes, Ekaterina, can you just see my presentation? Yes. Well, talking about comorbidities, we know such comorbidities which imitate the symptoms of asthma and worsen the clinical manifestation. This is rhinitis, dysfunction of vocal cords, and other comorbidities, obesity, metabolic syndrome, diabetes, mental diseases, and they may also worsen the progression as well as GERD, and CVDs are also here. As Natalia mentioned, females with late onset of asthma have high risk of cardiovascular diseases. Yes, there are lots of meta-analysis. It's one of them. Lots of patients included, over 400,000. It clearly demonstrates that asthma is related to increased cardiovascular risk, and this meta-analysis was also mentioned, higher risk of CHD, and more frequently in females. If we look at prognosis of the patients, we see that survival in patients with cardiovascular disease together with asthma is that lower curve. It's much worse compared to those who do not have asthma or just have cardiovascular diseases, and compared to those who have asthma, but these are children under 18. So there is a direct correlation with the worse forecast for these patients. When we talk about cardiovascular comorbidities, well, they make their contribution for patients with asthma. In the first place, they imitate the symptoms of asthma. When we have to make differential diagnostics, whether the patient with the cardiovascular pathology has asthma or not, they may influence severity of progression, and then also they may increase cough, shortening of breath. For us pulmonologists, it's important for this cardiovascular disease to be properly treated and controlled to decrease the burden of asthma, and treatment of cardiovascular diseases, we understand that, may worsen progression of asthma. Talking about why we make differential diagnostics between COPD and asthma, the clinical symptoms, shortening of breath, cough, may be similar, and when you see rattle, shortness of breath, and uneasiness in chest, and the symptom may be worse at night, in the morning, allergens, cold air, after taking aspirin or beta adrenal blockers. If we see in patients atopic diseases in patient records, but also a genetic predisposition when there is family history of asthma or other allergies, if we hear, so there are dry sibyllin rattles, we see eosinophilia and lung function, also impairment, so FAF first, second, and we see also worsening of S, and these are the signs which speak about asthma in a patient. So we need to follow the algorithm of diagnostic. We need to understand all of the symptoms to perform diagnostic and lab tests. Also, we need to look at eosinophilia. We need to study the lung function. We need to send this patient to allergologist to prove or exclude allergy diseases. And we need to exclude the disease which may imitate asthmatic symptoms or worsen its progression. And cardiovascular diseases are on the list. And also medication, ACE inhibitors, are very frequent for patients for whom we need to exclude asthma, the patient who is coughing, and he needs to undergo this algorithm of asthma diagnostics. We try to identify the time correlation between ACE inhibitor and onset of the symptoms, and also they may trigger cough, and the pulmonologists, they encounter such patients quite often. Non-steroids, anti-inflammatory and beta blockers that we discussed today so much. Talking about treatment of asthma, so our goal is to get to the situation of control. The current control are the symptoms over the last 4 weeks, and symptoms more frequently than twice a week, and then the need of beta-2 agonists more than twice a week, worsening of lung function, and so on. And we need to assess and decrease the future risk, the risk of worsening the progression, exacerbation, loss of lung function, and adverse events. And for cardiovascular patients, we use our clinical guidelines. This year, our guidelines were approved by the Healthcare Ministry. They are on the website of Healthcare Ministry of the Russian Federation. And we know how we start. There are 5 stages. First, second stage, this is mild. Third, moderate severe, and number 4 and 5, this is severe asthma. Well, what I should mention here, starting from the first stage of treatment, we must use the low dose of inhaling glucocorticosteroids, and together with beta-2 agonists as formoterol or beta-2 agonists. And the same, we may conclude based on gene 2021, and they are split into 2 parts. The first area here, so this is for patients who receive inhalation hormones plus formoterol, and they may use if needed. And the second option, when there is basic therapy, and if needed, the patient may use the short term, and the hormones are recommended for the short-term action beta-2 agonists. Despite that, our recommendations say that the inhaling asthma, we need to use glucocorticosteroids. So many patients, they continue. This is one of the analysis. And this is the data from the UK. So, and over 39 used the inhalators. So, and for also at least 3 times a day. So this is a lot. A need for the short-term ones. And this is also huge numbers, and it is proved that supporting therapy was not enough. So 12 pieces per year, and 38 patients who died used basic therapy. They had less than 4 inhalers, and 80% of patients had less than 12 inhalators of supporting therapy. So I mean the SABR, they use the SABRs a lot, unfortunately. And it is clear patients that are prescribed more than 3 packs per year, it's less than 1 inhalator per quarter. The more they use SABR, the more they turn for emergency care and admission, and the more they use corticoids. So for patient safety monotreatment in SABR was just cancelled at first steps, at first stages. We need to use low dosages of inhalator corticoids, and this is very dangerous because of elevated death risk. Speaking about these gene stages, if we look at the bottom, he's getting basic treatment with a share of inhaling glucocorticosteroid, and he doesn't use SABA. We need to increase the dosage, the volume, and for the patient who is get inhaler with a low dosage of hormone and formoterol, they may use everything as one inhalation. And starting from the 3rd stage, morning, evening, and also inhaling if necessary. Why? To timely increase inflammatory treatment and prevent exacerbation. Formoterol in low dosage is safer compared to short-term broncholytics, quick dilatation like sorbutamol, and very few side effects short-term. Beta-2 agonists, they were already mentioned, the adverse events we still expect. I'm not going to just read, you may read at the bottom, tachycardia, hypokalemia, longer QT, and we should be careful for cardiac patients. So beta adrenal receptors in myocardium. This is the myocardium to the left of healthy, and the density is increased by 2-fold in a person with the left ventricle myocardium. And what are other opportunities? Cholinelytic plus inhaling glucocorticosteroids, which decreases the need for SABA. And we have only tiotrope, the only option here. We know its effect. It's highly selective for M3 choline receptors. It blocks them, and we get the bronchodilation, and there is less sputum in the airways, and also we have anti-inflammatory. We can start tiotropium from stage 4 to 5. We may use tiotropium without beta-2 agonists together with the glucocorticosteroids, and especially with angiostenocardia, tachycardia, decompensated heart failure, and we have the opportunity to do so at 3rd stage, even tiotropium in 1 dose in 1 inhalation, 2.5 milligram, and also there was review analysis, 7 studies. Cardio safety is high comparable to placebo. As for recommendations of treatment of cardiovascular disease, I spoke about inhibitors. We should not forget about cough. As for aspirin, if a patient has aspirin asthma, usually this aspirin 3/8, asp polyposis, and non-standing of the anti-inflammatory agents, and it was demonstrated for asthmatic patients that non-selective beta blockers and high dosage caused moderate and severe exacerbation. They should not be used for asthmatic patients. Well, as for clinical recommendations, so in GIDA, there is no mentioning of beta blockers, and the British Thoracic Society does not recommend that, even iodine drops, and the National Institute of Heart, Lungs and Blood from the USA suggests to use non-selective, not to use non-selective beta blockers, and perioral oral timolol and diffusion of propranolol was related to significant risk of asthma, and oral propranolol, bisoprolol, atenolol may be related to lower frequency of exacerbation of asthma. Natalia spoke about the instructions. We should not forget about that. Bisoprolol and metoprolol has contraindication. Severe atenolol is with a care. The third is a contraindication. To finish the conclusions, today we understand that cardiovascular disease really worsens progression of asthma, which increase in its place the risk of CVDs, and treatment is more complicated, but treatment of asthma should be done in line with the clinical guidelines, and we should limit the use of beta-2 agonists of short action. And we understand there is benefit from the use of inhalers. They may have low dosage of different substances, and we should not forget that we have tropium, promit, and respion, which is cardio-safe treatment of CVDs in line with clinical guidelines. Non-selective beta blockers cannot be used for asthma, and in aspirin asthma, no aspirin and selective beta blockers if they are indicated for patients with asthma. I will agree. The higher the dosage, the less selectivity. In smaller moderate dosages, yes, they can be used. Thank you for your attention. Thank you very much, Marina. You see, dear colleagues, we just discussed so many details about asthma and cardiovascular diseases, and this is really an important topic. And this is not the topic which was widely discussed, and COPD raised more interest. Now this problem is widely discussed by cardiologists and pulmonologists, and that's great that we have a consensus. And also, dear colleagues, please ask your questions, write your questions in the chat. We will try to answer all of your questions, and allow me to give floor to our next presentation. That will be quite an unusual presentation. We are going to speak about expanding our knowledge about well-known medications. We are going to speak about the influence of medications which have been used for a long time to treat cardiovascular diseases, and how they impact the severity of respiratory and viral infections. Well, actually, this problem became relevant during the pandemic. and we received the maximum information during the pandemic about the impact of different cardio medications on severity of COVID progression. Why it happened? Because patients with coronavirus are usually elderly people who have lots of diseases, who have comorbidities. And if we look at active, almost half have hypertension, 1/3 obesity, then ischemic disease, diabetes, chronic heart failure, atrial fibrillation, COPD, stroke, and cancer. And those people, before getting infected, before coronavirus, they received treatment related to their disease. And also, I should mention the following, that all of those comorbidities, in case of coronavirus, unfortunately, they increased the mortality risk of patients at hospitals. And we see here the risk prioritization. The maximum risk is for stroke, atrial fibrillation, CHD, and the lowest risk for patients with COPD. Cardiovascular disease had maximum impact on the outcomes of coronavirus infection. That's why it turned out that the impact of different treatments was well studied on coronavirus. Antithrombotic treatment in the first place, because the main target of coronavirus is endothelium of vessels, and endothelium dysfunction, hypercoagulation, and activation of thrombocyte developed. And we know micro and macro thrombosis are quite frequent complications of coronavirus. And it was also learned that for coronavirus there is active proliferation of megakaryocytes in lungs, heart, and kidneys. The platelets may be elevated, as well as the aggression. Big studies assess the antiplatelets impact on survival of patients who were hospitalized with COVID, 34,500 patients. The patients who had aspirin and had no aspirin before having COVID. And we see that the patients who had aspirin had less mortality, better survival, and the frequency of bleeding was no different in those groups. Another big analysis from the US, 35,000 patients, and we may see that pre-hospital medication with the aspirin was associated with the low level of 14 and 30 days mortality in patients. The authors emphasize that the main factor was that the patients were taking aspirin when they had been diagnosed COVID, not as a new treatment for acute disease. And there is a big range of COVID studies united under recovery. So these are randomized trials, and in this randomized trial, they study the influence of aspirin on hospital progression of COVID infection. So here the results are more modest compared to other studies, but still there was a moderate improvement in 28-day survival, and also improved monthly mortality by 1.2%. According to active register, antiplatelets also improved survival of patients, but we don't have statistically significant data and accurate data for for aspirin, but for clopidogrel, ticagrelor, prasugrel, for CHD, if they were taken before COVID, they decreased the severity and hospital mortality for patients with the COVID. Another interesting data about oral anticoagulants, according to most data, previous treatments with oral anticoagulants prescribed as indicated. This is for patients who were treated at least half a year by NOACs. We see accurate decrease in the risk of hospitalization and combined risk of hospitalization and mortality in patients with coronavirus. Another study, also preliminary treatment with oral anticoagulants and approval as well in the outcome. So these are accurate results on decrease of overall mortality and mortality related to coronavirus. And by the way, bleeding death rates were even lower for patients with a high level of compliance for oral anticoagulants. According to active register, we also have the same data that atrial fibrillation patients, if before hospitalization they had oral anticoagulants, their hospital mortality was low, but that was for direct oral anticoagulants. We did not see that for warfarin. Well, probably one of the most interesting data are about hypolipidemic treatment for coronavirus patients. In the very beginning of the pandemic, it was turned out that the statin have their anti-inflammatory effect for COVID-19. We may see the chart in blue. These are statins, and we see that the patients on statin have less CRP, interleukin C, and neutrophils, which was also manifested clinical results. Over 5,000 patients participated in this trial, and we see that the optimal survival, red and blue, so they had different types of statins, and green, so there were survival patients who had indications, but they were not taking statins before hospitalization, and that was dosage-dependent effect. Higher dosages of statins, they were related to higher decrease in mortality with a severe coronavirus infection. Another meta-analysis of observational studies, 35% of decreased mortality risk for patients who received statins, and also probably the biggest meta-analysis, almost 148,000 patients. We see that the relative risk quite significantly decreased for patients, I mean the death risk for patients who had statins, and the authors emphasize that only permanent use of statin before hospitalization decreased mortality in these patients. So the active register prove the global register. Patients with CHD who took statins before hospitalization, they had lower mortality risks. But what is very interesting here, interesting data was published. That is a huge observational study, analysis of medical documents, 4.5 million patients. And we see that different hyperlipidemic treatments, which includes statins or no statins, also decrease the risks of hospitalization, and there was a trend towards decreasing the risk of death. And this meta-analysis analyzes the statin, rosuvastatin in particular, and hyperlipidemics, and their impact on severity of coronavirus infection is mostly related with the following. Statins directly prevents the viruses from getting inside they prevent them from the replication, and the increased lipid level in the membrane is necessary for the virus to get inside, and also for replication inside. So the lipids are required. Any hyperlipidemic treatment will prevent the virus from getting inside the cell and will prevent viral replication as well. And another interesting story is treatment of hypertension, how it correlates with severity of coronavirus infection. And well, this is the study which puts the final stop here, the full stop. If the patient has hypertension, of course, his survival is worse compared to a patient who doesn't have arterial hypertension. But if this is the patient who is treating it, who is taking antihypertension drug, so his survival is much better compared to the patient who's not being treated. And also, what is peculiar here, when patients take inhibitors of RAS inhibitors, and this is one of big analysis with for 2 million patients. What's interesting here, patients with isolated hypertension were included, so that there was no impact of comorbidity. It turned out that ACE inhibitors and serotonin survival, event-free survival for coronavirus is better compared to calcium canals blockers. You see the hospitalization charts, and we see the same for intubation and mortality inhibitors, and better than the blockers of calcium canal in terms of their impact on survival of people with arterial hypertension in case of coronavirus. And also in active, we saw that ACE inhibitors prescribed by indication decrease the risk of mortality and have a positive effect on mortality. And also, if they took certain before hospitalization. Positive effects of RAS are usually explained by the following. Coronavirus causes a disbalance in the renin-angiotensin system in terms of it increases the concentration of angiotensin II, which is damaging not only cardiovascular disease but lung tissues as well. It has a pronounced destructive effect, and ACE inhibitors and serotonins, they compensate this balance of renin-angiotensin system and prevent these effects in angiotensin II. Beta-adrenal blockers, well, there is not enough data in the literature how they affect progression of coronavirus, but according to our information, if they are prescribed as indicated, they decrease the mortality risks for acute coronavirus stages. And colchicine, well, it's quite interesting information. Why we are discussing that in this lecture? Because we believe that it's a cardiological medication. There are two big studies who were finalized. Colcott patients 2 months after infarction, they received colchicine after that. They were followed for 23 months almost, and we see that primary and secondary endpoints and decrease risk of stroke, and also emergency hospitalization. And of course, this is the trial LODOCO 2, and cardiovascular death in myocardial infarction, ischemic stroke, or ischemia during coronary revascularization. It decreases these risks, and by 31%. And the data about efficacy of colchicine in COVID-19 are widely published. There are several big meta-analyses, and the biggest trial is for outpatient clinics. It's called Call Corona. This is not an observational study. This is a randomized control study, which is very important. And according to this study, when colchicine is prescribed, starting from the first days to outpatient patients, and it decreased mortality by 25% and hospitalization that was statistically significant, and hospitalization by 25%. And there was a trend towards decrease in the need of artificial lung ventilation and decrease the risk of mortality. And the authors who did the study, they believe that colchicine is the first oral drug which may be used for treatment of non-hospitalized patients with the COVID with the proven results. I should say that Moscow State University Clinic did a nice trial called Colorit. Mr. Mariev was leading that trial on colchicine impact on hospitalized patients. So these were more severe patients compared to Call Corona. And in this study, colchicine also decreased severity of infection progression in line use and shocks COVID. The meta-analysis performed on colchicine, and we see an observational and randomized trials, significant decrease in risk of mortality, and big systematic review and meta-analysis over 17,000 patients. The minus 43%, this is the total in this meta-analysis. Several randomized clinical trials are here, and there are lots of them. They were different from observational cohort study. In observational cohort, the results are better. In randomized, less, minus 25%. And from recovery, weighted used for hospitalized patient with quite severe infection. And the trend was towards positive results. Well, the positive effect of colchicine, and it stops replication of SARS-CoV because it destroys the microtubes, which are important for the virus to get inside the cell. It inhibits inflammasomes, NLRP3 with decrease of interleukin production, and fights against the cytokine storm, suppresses activation, migration, and adhesion of neutrophils to endothelial cells, suppresses generation of extracellular traps of neutrophil. This is an important mechanism to prevent microthrombosis and prevents migration of leukocytes and microvessel thrombosis through inhibition of activation complement, and prevents damage of endothelium. That is quite interesting effects which are discussed. And spironolactone, I must speak about it, and it's quite widely discussed, and the effects of spironolactone, anti-androgenic, anti-inflammatory, antioxidant, antifibrotic, and its impact on apoptosis of cell. I'd like to quote a study from a Moscow State University Clinic. Mariev Vyacheslav also led this trial, called Biscuit, bromhexine and spironolactone for patients with mild and moderate COVID. There was a decrease in hospital stay in the trial, and the fever duration also decreased. So, dear colleagues, with a decrease of risk of severe COVID progression, we may associate antiplatelets for CHD, NOx for atrial fibrillation, ACE inhibitors, angiotensin, statins, exitimide, colchicine, spironolactone, and also BABs for arterial hypertension, CHF, and chronic heart failure and CHD. And we need to make sure the patients adhere to treatment of their pathology, and we need to act in line with the clinical guidelines. May be helpful for this patient if he gets infected with coronavirus. Dear colleagues, I would like to thank you for your attention. And we have questions. Our doctors are so active. Marina, the first question is to you. What is we know that for asthmatic patients, we need to use what is in the guidelines, and the hormones for beta-2 agonists beta-2 for hormones. So this is the combination number one, anticholinergics. If we not control asthma, we need to decrease the emergency medication when there are exacerbations and combinations. Anticholinergics are added. Hormone plus anticholinergic is cholinergic are used less. Only there is a comorbidity, cardiovascular disease, uncontrolled. For example, we have patients that cardiologists could not manage arrhythmia, and we removed beta-2 agonists, and we used the inhaling glucocorticosteroids when there is uncontrolled cardiac pathology. So this is the combination of glucocorticosteroids, and usually, so this is a combination with the perorol glucocorticosteroid for COPD after they are discharged from coronavirus hospital. If talking about COVID, we prolong the hormones. We try to do that for a short period of time, not cancel that, because it was severe, so the person could have high dosages, and so we gradually cancel that several days after discharge. Well, yes, talking about exacerbation of COPD with COVID, then a short treatment, so the exacerbation is treated like in clinical guidelines, 7 days, high dosage. If we're talking about exacerbation of Hobble, and then cancellation, probably should not do that. Depends on the situation. If he was severe with high doses of glucocorticosteroids, yes, then we cancel that gradually, and then he should get basic treatment. Ekaterina, allow me to add, and if the patient with COPD has cardiovascular diseases, especially heart failure, it is better to use inhalation glucocorticosteroid, because systemic oral glucocorticosteroid will decompensate the heart failure. Yes, we try to do that sooner. Dear colleagues, another question. Probably we have two speakers who may answer. So stage 4 and 5 treatment of asthma. So are there any medical interactions when we treat CHD? I will not focus on that. The patient who is getting this type of treatment, this is severe asthma, well, he has high risk of cardiovascular complications, then we must control both asthma and cardiovascular disease. And as for medicinal interactions, well, Marina, we use clinical guidelines. I do not think there are some medical interactions. No, you need to be very careful with beta blockers, because this is severe asthma. Even we look at selective ones, and then stage 4 and 5, it's when it's asthma not controlled, then target therapy. And also about asthma, we have a question, yes? Maybe you could clarify this question. Maybe you mean some specific drug. And also, there are no limitations for asthma. Yes, in some cases. How we can think about CHD compensation in a COPD patient? Yes, progression of CHD when COPD is progressing because the shortness of breath, other common symptoms, and other ones, AVEX symptom. Of course, we look at structural and functional echo, diastolic dysfunction of left ventricle. Also, elevated indicators speak about dilatation and lab diagnostics, markers of heart failure, and NT-BNP. And should we decrease the dosage of inhaling glucocorticosteroid for patients with asthma and CHD? You see how interesting the question is. Who will be the first? We need to look at the stage, at severity of asthma. Inhalation glucocorticosteroids should control. If it's severe, these are high dosages, irrespective of ischemic heart disease, coronary heart disease. If it's controlled at higher dosages, then we should use them. We may decrease the dosage if we have proper control and treatment with inhalation hormones. 3 months, we try to decrease the dosage. Only step-down therapy if asthma is under control. The key word is control over asthma. And asthma, dear colleagues, how to properly do treatment with partially controlled asthma in early post-infarction period. We do not have some specific studies. We do not have the proof how to do that. We can just rely on our experience. I would say the following. The risk from beta blockers for asthmatic patients. It's not that just these medication may cause exacerbation. No, just the reason is different. When we partially control asthma, we won't be able to differentiate why the patient is getting worse. It may be the beta blockers or poor control. If we are talking about infarction patient and small dosages under control, I would just prescribe it because we have clear proof that the patient with infarction and chronic heart failure, they need this treatment. And as for asthma selective beta blockers in early post-infarction, yes, as for partial control of asthma, and we need to avoid the need for SABA. Probably we need to increase the volume of inhaling glucocorticosteroid to montelukast, probably to control beta asthma, and to have no need in this short-term effect drugs. Why the mortality rates from COVID increased over the past months? Well, dear colleague, I think it's quite evident. A complete ignorance of safety measures at universities, in public places, and according to official data, there is low level of vaccination. Only 30% of the population is vaccinated compared to other countries. We are really behind, and now there is a seasonal increase of the diseases, and the doctors, they publish statistics how many vaccinated and non-vaccinated patients they have. Well, the statistics is almost the same among those who were hospitalized well, they have quite a severe. Non-vaccinated are 90 to 95%. The vaccine may not just prevent, but it prevents the severe progression. So we use the Moscow State University scheme since the beginning of the pandemic. In colchicine, 0.5 milligram. The first 3 days, 1 milligram, 2 pills, and then over the next days, during 28 days, we take 1 pill per day. We use that scheme for a very long time. Will you use the minimum dosage of inhibitors and statins in case of pneumonia on top of antivirals, 2.5 enalapril and 5 enalastatin? Dear colleagues, I always emphasized in my presentation the positive influence is pre-hospital, pre-admission. So the patient with cardiovascular disease which has proper treatment before hospitalization, who had inhibited certain statins in the right dosages, has less mortality risks. And adding to Nova in the acute period of coronavirus, it's not for sure or which effect it may have. You may add something if you have some clinical indications like poorly controlled arterial tension, but to just expect such an effect like in pre-hospital use, well, Marina, that is the question to you. Systemic glucocorticosteroids for non-hospital pneumonia and signs of coronavirus. The patient has, well, glucocorticosteroids, we should treat them as our guidelines say. The indications for systemic hormones, well, this is ambiguous. It's either COVID or pneumonia. If there are hints about coronavirus, that should be coronavirus, then not from the first days. We need to look at the patient. If he continues to have fear and other indicators who are growing, like in our clinical guidelines, we have indications for systemic glucocorticosteroids in case of COVID. Yes, dear colleagues, yes, the problem is like this. So we are just finishing at 4 p.m. sharp our symposium. Dear colleagues, I would like to thank all of the speakers for really great presentations. I hope that cardiologists and pulmonologists, our union will be very fruitful. We continue our cooperation. I would like to thank everybody who joined us at our symposium for your questions. Thank you so much. I would like to wish you health and goodbye. Stay for the next symposium. Goodbye. Goodbye, dear colleagues.
И здравствуйте, Игорь Иосифович. Игорь Иосифович, здравствуйте. Ну, так приятно, что мы между симпозиумами еще имеем такую возможность увидеться, потому что мы лишены уже почти 2 года такой возможности. Поэтому рада всех.
Прошу прощения, я что-то не в тот зал вошел сейчас.
Да, ну,
не в тот, да, потому что у нас сейчас симпозиум вот с Игорем Иосифовичем. Я вот думаю, мне выходить или...